Okay, well, thanks everybody for joining us today. Aaron Friedberg's joining us, and he's discussing an important topic. It's on pre-exposure prophylaxis to HIV, which is complicated to say the least, but an important topic for us to know well. So, Aaron, thanks for joining us.
My pleasure.
I'm going to drop this off to the right side of the screen. So
sounds good.
Just don't click on that because sometimes it'll stop the recording.
Oh, yeah, I don't want to do that.
All right, you're good to go.
All right, well, thanks for having me, guys. I wanted to do this talk because, here we go. I wanted to do this talk because I had a patient come in who was, without a doubt a candidate, and I wanted to know more about it. And so we talked about it, and I sort of read a lot about it and wanted to share it because this is really something where a lot of times I think we feel nervous because this is, medication that ID prescribes, and there are a lot of criteria, and it's a lot to do in a clinic visit. And so I want to just kind of talk about it to try to hopefully make us all more comfortable with talking about this with our patients and hopefully feel comfortable prescribing it for the right candidate. So we'll go ahead here. So background, in terms of our objectives for today, these are my two. There's a bit involved. We'll go through it in terms of, who should you prescribe it for and why, and how to do it and how to do it safely. And then what can you use both to inform yourself and also good patient resources. So hopefully we'll all know all of this by the end of the talk. So obviously HIV is bad, right? I mean, this is a terrible illness with more than 2 million infections a year and more than 50,000 in the U.S. alone. So what can you do? I mean, there's a lot you can do to reduce HIV. It's not just, what I'm talking about today. There's education and barrier methods, circumcision. This is actually like 60-some% effective when they've done studies on men in Africa. So, but not for everyone. Treating other STIs and drug treatment, but PrEP is the big one, and that's the one I wanted to talk about today. So PrEP, great acronym, right? Pre-exposure prophylaxis. We should all have great acronyms for these treatments. So who do you choose? So there are obviously different populations that are at more and less risk for HIV transmission. I think this chart kind of points in the right direction of just on a per-encounter basis for all the ways you can get HIV, what's most likely. And to me, what stands out are two big ones. One is receptive anal intercourse, so 1 in 72 encounters. Now, this is definitely one of those known unknowns. We'll never know really how many people are going to get infected per encounter, but by population study data, this is probably about the best we're going to come up with. That's pretty high, right? And people that are having 5 or 10 partners in a year are going to be at very high risk, especially if they're practicing receptive intercourse. And I think the other interesting one is if you look at receptor inserted penile oral intercourse, 0 to 4, or inserted penile vaginal intercourse, 1 in 2,500. That's a tremendous difference. I mean, we're talking about a 20-fold difference between these kinds of sexual activities. So, not that all these kinds of patients aren't going to need potential protections, but there are definitely higher yield targets, and that's part of what a lot of the tests for deciding who's right for this therapy are aimed at. So basically, if you're trying to figure out who should get it, talk about the last 6 months. So you really should just focus on their sort of recent activity. These are the things that are bad. Is condomless penetrative genital sex with non-monogamous partners. If they are monogamous, if the other partner has HIV, they have sex using drugs, if they've had any STIs, and then if you're concerned, you should always test them. This is part of the preparation for PrEP, even if they don't have any symptoms to check. And then the number of sexual partners, more is worse, particularly more than 5. And then what screening tools are there? So what can you use in clinic to help identify people? Now, most of these are directed at men who have sex with men just because that's kind of the higher yield population. One of them is the San Diego Early Test Score. It's a web-based thing, but it's not applicable to all populations. There's also the catchily named GRUNSM, or I think it's supposed to be high-risk men who have sex with men. That's a 7-question screening tool that was validated in studies. Again, mainly for men who have sex with men. Consolidated basically from a bunch of active HIV studies. So this is what the online scoring tool is, and I've kind of played around with it a little. So this is if you've had one male partner and no other risk factors, your risk meter, and this will change, is 0. You can play with this online too. I'll give you the link, but let's say you've had 5 partners and you didn't use condoms, but none of them were infected, no STIs, higher risk, but not that bad. You throw in a single partner that had, infection, much higher, obviously, and you throw in a single STI like chlamydia, that's going to bump it again too. obviously, if you make all these high, it's going to be super high risk. But yeah, these are big differences in small things. So it's going to be helpful for this population. And then for the core acronym 7-question test is basically age. So 18 to 28 is a bad age bracket to be in. How many partners they've had. More than 5 is bad. More than 10 is worse. And then if you've had anal receptive sex is bad. You assign a certain number of points. Basically, more than 10, you should talk to them about PrEP. So in terms of the risk factors, things like drug use are bad, and some things are better and worse. So IV use of heroin and cocaine, sharing needles or injecting a shooting gallery are bad, but if they've been practicing, safer injection, using sterile equipment or, having been on some sort of a controlled medication, methadone or buprenorphine, or having mental health support, that's actually a lower risk for HIV transmission. And then the other question is, what do you test first, or who shouldn't be getting PrEP? It's obviously a big one too. Obviously, QHIV is bad. You could promote resistance. And how do you check for this? Well, you can do an HIV test. The best way to test is a 4th-generation HIV test, which that is what our lab has. They use the C24 antigen. And if you have any concern for QHIV, just get the PCR. Of the people in studies who were on PrEP and then later developed resistant HIV, retrospectively, by testing those samples going back, all of them, or almost all of them, had acute HIV, but it just wasn't picked up. And so if you have any suspicion, just do the PCR test. Way to check. And basically do extra testing if the test can determine it, or if they had any high-risk activity within 4 weeks. Renal dysfunction is another big one. Basically, if their GFR is under 60, you just don't prescribe PrEP. There's no alternative, unfortunately. This is because of the tenofovir specifically. And if they have any risk for renal dysfunction, high blood pressure, or diabetes, just check a UA and urine function, and you have to do it more frequently and follow up, and we'll talk about that. If they have hepatitis B, so it's not that they can't have hepatitis B. Tenofovir is actually like a first-line treatment for chronic hep B, but you may want to coordinate that treatment with the PrEP. And so this is one where, honestly, you're going to coordinate this with ID if you're treating. For osteoporosis, so tenofovir, the other thing other than renal is bone density. It's known to have decreases in bone density. Seems to be a finite risk. They sort of drop in the first 12 to 18 months, and then they sort of stay there. But it may be more of a problem for younger patients, particularly like adolescents who are being prescribed this, because they actually do lose bone density even during those bone forming years. So it's something to think about. It's not that they shouldn't be on it. You have to be more cautious. And you have to see if they have any risk factors for osteoporosis too. Get a DEXA if you're at all concerned. And then pregnancy, and basically do a pregnancy test first. Initial tests you're going to do. Again, it's not that they can't be on it, but honestly, you're going to be coordinating this with OB-GYN or someone, because both drugs, the M-trazodone and the tenofovir, are category B. So it's not that you can't get them in pregnancy. I mean, certainly people that have HIV are on them, but you have to weigh the benefits risk. Do they really need it? It's worth the risk, because it may have issues with bone density and disease going forward. That was the only real problem they found, actually. They had studies where we were on PrEP, and they looked for problems later, and really any factor you would care about wasn't affected, but in all those studies, they stopped the PrEP as soon as they found out they were pregnant. So you didn't really see the later pregnancy data. So who are the best candidates? These are the definite people you want to be working on getting it for. Men who have sex with men or transgender women who have high-risk behavior in the last 6 months. Any condom-less anal sex with multiple anonymous partners. Main partner who has any of these risk factors. Of the people who got infected, something like 68% who got it from their main partner and a main partner with risk factors. So you have to watch out for the partner too. And then anyone who had an STI in the last 6 months for any reason, if they had it, if they're men who have sex with men, you should think about PrEP very strongly. And then people who are serodiscordant, the partner has HIV and the partner has detectable virus. People who are also, if they're just in an epidemic area like sub-Saharan Africa, not necessarily our patients, but be an issue. People who are decent candidates, not quite as strongly recommended, are men who have sex with women with infrequent condom use, where it's a low prevalence area, but the women are high risk, like sex workers or drug users, or women who have sex with men with high risk partners, like men who use IV drugs or bisexual or in high prevalence areas. And then anyone who uses IV drugs, shared equipment in the last 6 months, is probably a decent person. So what resources can you use for this? So there's a few good ones. Up to date, honestly, the basis for a lot of this talk, it's very long, and so it is worth going through, but it's not like you can review this in 1 minute when you're in clinic. There's a lot of information there. But it's a good place to look for specifics. And then in terms of other things that are out there. So CDC, it has the PrEP guidelines. Again, they're even more exhaustive, so it takes a long time to go through those. AIDS.gov is a good online resource for patients. CDC also has a good two-page summary that I'll show you. And then whatisprep.org. If you have a really interested patient that wants to see everything, it's got all the websites in one place. It's kind of a place. I'll show you what these look like. So this is the AIDS.gov site. Again, very clean. It's got nice flat graphics. It's very appealing, I think, for folks, and it's easy to navigate. This is the two-page CDC PrEP information sheet, which is very useful. If you Google HIV PrEP handout, this is the first thing that comes up, so it's an easy one to find. And I can share this with you, too. This is the CDC site. There's some overlap in terms of information with what's here and what's on the AIDS.gov. It's just organized differently. It's kind of in a long list of questions people would have. It's a nice one, too. Then this is the What is PrEP. It has a video of how it works, and then they have a bunch of links at the bottom. So the therapy, this is a big one, is really right now there's only one therapeutic option, which is Truvada. It's a combination of tenofovir and emtricitabine. You take it once a day. There are other things being studied, but none have been approved yet. So it's both not only tenofovir in other forms like gels, actually it's 100 times more concentrated in, for example, anal or vaginal tissues than a gel as opposed to the pill, but it doesn't work as well in studies, so it just hasn't really panned out. So but they're trying other drugs too, and that's maybe more in the future. Basically, you prescribe it as a 90-day supply. You only renew it with a completed HIV test each time, so that kind of keeps people coming and make sure you're checking on symptoms. And you always want to counsel them to use condoms too. You don't want to create problems by making them think that they're able to practice less safe sex, and counsel on safe drug use as applicable, and also the signs and symptoms of acute HIV. So lymphadenopathy, fever, malaise, or a macropapillary eruption. You want to ask them about each visit and also warn them to look for it, and definitely have the condoms that they have in possession. Incidentally, there is another form of tenofovir that's actually less associated with both the renal and the bone problems, but it just doesn't seem to work well for PrEP. It's probably because it has lower mucosal levels. Probably a no-go on that one. So Truvada is a big one. How effective is it? Well, the big one was this IPREC study. Basically, the study showed 44% effectiveness, but the people who were actually taking the pill, it was 96% effective. And the 96% actually was a modest number, honestly. The people who had drug levels showing they were taking it more than 4 days a week, so not even that great of adherence, right? More than 4 days a week, no one got infected. And this is really, now this is men who have sex with men. Really what it seems to show is that it's different for men and women. That, as with most things, it's harder for women than it is for men. And for men, it probably just concentrates more in the anorectal tissues. For women, they probably have to take it 6 or 7 days each week to really get the effective dose. So then the other question is, how long does it take until it works? For anal receptive sex, it is 7 days. For women who are vaginal receptive sex, 21 days. They have to wait longer. And again, this has to do with concentration being lower than the tissues of the drug. And we were talking about how important is adherence. It depends. Always tell them to have, good adherence. But like I said, maybe 4 doses a week is probably honestly enough for men who have sex with men. And for women, they probably need to take it every day, or it's not going to work that well. So therapeutic issues, there are some problems. Resistance is one. The concern is that if you take it, you might have resistant HIV if you catch it. Like I said, the big issue in retrospectively looking at samples was they actually had it and they just didn't catch it. So as long as you're assiduous about prescribing it, any suspicion of acute HIV, just ordering a PCR, you should be okay. Cost is another issue. It's sort of hard to tell. Overall, the consensus is this is cost effective, but it's, I think, $14.25 a month for, it's not covered by insurance. So that's a lot of money. It may not be affordable for everyone. You got to set to pick your population, right? They do have a patient assistance program, for whatever that's worth. So if you're wondering about that, you can always see how much money is covered. And then there are ultimate regimens. So the only one that's approved is the once-a-day Truvada. But they've done ones where it's more event-dependent. You take it for, say, a double dose before you're going to have sex, or for the week before you're going to have sex, for men, or 3 weeks for women. And then you take it during that time, and then you take it for a certain period afterward. And at least in the one they did with men, they ended up taking an average of 15 days a month anyway. And actually the effectiveness was quite good. It was 70%, 80%. It was quite effective. So I wouldn't recommend it. The only way it's approved is daily. But if you do it that way, it may actually work pretty well, at least for men who have sex with women. For women, they have to start earlier and take it longer afterward. but it probably would work well. But probably better just go every day. It's the way it's approved anyway. And I think I said in my talk I wouldn't talk about alternate regimens anyway, so I would not recommend it. The side effects. So about 10% have nausea. However, it tends to resolve within the first 4 weeks, and for most people it does. The bone density issue, it basically drops to a plateau after about 12 or 18 months, and it doesn't resolve, but it goes back to the normal rate of loss once you stop the medicine. For the GFR, so you do have to watch it, and we'll talk about monitoring. But basically, if the GFR drops below 60, you have to stop the drug if they can't be on it anymore. If they were normal and they drop by 20%, you basically retest them in 2 to 4 weeks. It's continuing to drop, stop it. If not, you just continue to monitor closely. If they have any new protein or anything else in the urine, just continue to monitor very closely, probably every 4 weeks to make sure there's no change. So in terms of monitoring how often you have to do it and what you have to check, so every 3 months, get HIV test, screen them for HIV symptoms, do an STI screen regardless of whether they have symptoms or not, talk about adherence, risks, and if there are any side effects. If they have those risk factors like high blood pressure, diabetes, or other things, check your creatinine every 3 months, do a pregnancy test every 3 months as a woman, and then re-prescribe, of course, that would get that. And then every 6 months, you want to do the renal function regardless of whether they have any problems, and do a UA if they have any risk factors every 6 months. Another question is, how long do you treat? Are you putting this on for life, or how long are you going to do this? So it depends. As long as they have the risk, it's okay to keep prescribing it long term. But if you are going to stop, do an HIV test when you're stopping, and you should tell them to wait, at least 1 month after last high-risk exposure to stop taking the drug, because you want to make sure it's still in the system. And then as far as people who have a partner who's HIV positive, they've done studies, and it shows over and over again that the best treatment, most cost-effective treatment for those folks is to treat the one with HIV. And that once they are suppressed, the rate of transmission is near zero. So really, they don't need to be on PrEP if they have a stably controlled, negative viral load partner. PrEP is probably around 1,500 per ml, but really, if it's at zero, then it should be okay as long as it's stable. But it's okay to continue it, even if their partner says, well, yeah, my count is fine. If they have concerns about their adherence or they're still engaging in high-risk behaviors, it's okay to continue it, even if it's viral. You don't have to. So overall, we talked about the objective, knowing basically what is PrEP, how do you use it, and what do you do to keep an eye on it. To assess the risk, talk about what's been going on in terms of sex and drugs for the last 6 months. You can use those tools for men who have sex with men, like the San Diego early test or the HIRI-MSM. Know who's a candidate. So if they have a viral load in their partner, their serodiscordant partner, they're a men who have sex with men that has high-risk behavior. If they're heterosexual, they have a partner with risk factors or an epidemic region, or if they've been sharing any equipment or needles in the last 6 months, they're a good candidate. And then you shouldn't prescribe it if it's acute HIV, they have osteoporosis, their GFR is under 60, and you want to basically coordinate with a specialist with hepatitis B or pregnancy. You don't have to avoid it necessarily. For pre-testing, get an HIV, check their GFR. For Hep B testing, just do the surface antigen and then do antibodies for core and surface. You may or may not do DEXA, depending on whether you feel like you need it, and then pregnancy test if it's one. For therapy, Truvada once a day, prescribe it for 90 days. And then for monitoring, every 3 months, check HIV, check for symptoms, do an STI screen regardless of symptoms, check on adherence, risks, and side effects. And then if they need it, get a kidney function test and pregnancy test no matter what. Every 6 months, check kidney function and then do a UA if they have risk factors. And then in terms of what can you use, both for your patients and for yourself, up-to-date is great for us, and the CD guidelines are more comprehensive if you want to really go in depth and look at the studies. I avoided the details on those today because there are a ton of them. Basically, it's just better for men who have sex with women. For women who have sex with men, it's still pretty well. And then for patient resources, so AIDS.gov is great. CDC has both a nice website and a nice patient handout. And then What is PrEP has pretty much every resource you can imagine. So if they really want to go at it, that's where we go. So that's all I have. Thanks. Any questions?
Wonderful. Thanks. Yeah, really great.
Are there any questions from folks on the phone, or actually let me unmute their phone?
I have a question while we're unmuting. You said, do the HIV PCR. if, you know, you have a significant concern, how would you define that? Like if they've had a high-risk exposure within the last week or two, or I guess if they're on PrEP, they probably have had one, but I shouldn't assume that.
Yeah, it seems like it's really about symptoms. Like if there's any, I mean, and honestly, if they're asking for it, I would probably order it, but it seems like it's based on symptoms. If you have any concern for acute HIV, you know, it might look like they have a cold, but if you're at all concerned and you're thinking of starting PrEP, then you should do it. You know, you can always just wait too, but the worry is that you might be leaving them uncovered when they might benefit from PrEP. So I think, you know, if they're ready to start PrEP and they're a good candidate, if you're at all concerned about acute HIV, just test it. It's a good test. You know, if they have 0 viral load and their HIV test is negative, you're good.
Aaron, what would you include in the STI screen?
So I was a little iffy about that. It seemed to be gonorrhea, chlamydia, and syphilis, but they didn't talk about others.
Urine and blood.
Yeah. You're going to be doing it anyway for the HIV in terms of blood. They do say that it should be a plasma HIV test, but we shouldn't use the, you know, the ELISA toxin test for that.
So 2 questions.
We can speak up nice and loud so it gets recorded.
Okay. So first one is sometimes, occasionally, in the clinic, I remember years ago, there's a patient in the clinic asked us to give him some medication because he was ready to have some fun overnight.
Can you repeat the question real quick?
Oh, sure. So the question for those listening in was, there was a patient years ago who was asking for some medication because he was planning on having some fun overnight. And, you know, what do you do about that? Would this be a good drug for that? Like I was saying before, the only recommended administration is once a day. And as part of that, either way, you need to do all of this preparation ahead of time. The lab testing, the screening in the clinic. Because the worry is you could hurt someone. I mean, that's the real worry here is if you could kill their kidneys with the tenofovir if they already have, you know, CKD. You could worsen osteoporosis if they're already, you know, having an issue there. You could give them resistant HIV that they didn't already have by prescribing it during an acute HIV course. And so, you know, in terms of starting the drug, you know, while it's been studied as a sort of per event basis where it's not, either way it wouldn't be good for a single night. There's no study that's talked about a single night PrEP. There are studies that looked at, you know, these sort of per event strategies where you take, you know, 2 pills as a loading dose during the period, do it for a certain period after, say, a week. And while the results were fairly good, they weren't as good as taking it daily, and so they just don't recommend it. So, unfortunately, on a per night basis, you know, it's not like the emergency contraception where you can just take a Truvada and be okay. While there have been some regimens studied that are more short term, they don't recommend it at this point.
So basically, if we start a series of 4 weeks, start early.
Yeah, I mean, you know, if they do the testing and everything's okay and they don't have any other risk factors, you're not worried about acute HIV, you can start them on PrEP. But if it's a man who's having sex with men, it should be at least a week before they're going to have the event. If it's a woman who's having sex with someone else, then it's 3 weeks to get appropriate concentration of the drug. Again, at risk for getting acute HIV and then getting resistance.
So we need to tell them, hold down, you need to get this for a week.
Yeah, if the man is having sex with men, then it's at least, they have to wait at least a week.
Can we prescribe the Truvada to the patient, or we have to use ID?
No, and that's the point of this talk is that, you know, we don't need to go through ID, and the consensus is they don't want us to go through ID. You know, I mean, they're happy to prescribe it, I'm sure, but, you know, if they're otherwise not infected and are just looking for prevention, that as long as you feel comfortable doing these things and checking the things that we were talking about, you can prescribe it. It's absolutely something that's in the primary care domain. I think the time to coordinate with other specialists, or if they have hepatitis B or pregnant, you know, we want to talk with either ID or liver or OB-GYN respectively, but otherwise this is definitely in our wheelhouse, but I hope that we do.
Are there any questions for folks on the phone?
This is Chris Hanks. I have a quick question. And there's probably not an answer to this, but you know, when you were talking about using it in the situation of when they have a HIV positive partner, assuming that partner had resistance to the medications in Truvada, is there any suggestion of using other medications instead, or I'm guessing there's nothing on that?
That's an interesting question. I don't know. You're kind of stuck there because this really is the only pill that's approved right now. Like I said, they're working on some other agents and studies, but nothing's really gone through yet. But that's a fair point. If you're resistant and you're using the combination of, tenofovir and cytarabine, what are you accomplishing? I don't know. I'm not sure I have a good answer for that. Use condoms. That'd be the very strong recommendation. Use condoms every time. I guess that's all I have.
And if it's not a monogamous relationship, then Truvada would be helpful.
Yeah, there may still be an advantage there.
Yeah.
And then the other thing is some of the people, they thought may have, gotten a resistant HIV strain when they got infected, so it may not matter about the Truvada, and, there's only so much you can do at this point.
So the insurance wouldn't be a problem. The insurance.
It depends on the insurance. They're going to have to find out and see if it's covered.
Can you repeat what the cost was?
So the last I saw, which was I think from about a year ago, was that it was $1,425 a month uncovered. So you're talking about around $14,000, $15,000 a year out of pocket if you're not covered by insurance.
And that's just for the medication alone?
Just the medication, not the testing, not anything else, just the med.
And you said insurance companies do not pay for it, or
they should. It depends on which insurance they have.
Okay.
But I think in general they did.
Okay.
I had to go through a fairly lengthy PA with my patient, but it ultimately was paid for. They recognize that it's going to save them money in the long term.
Any other questions for the folks on the phone? So I have a quick question. So we, in our division, we manage probably 40,000 lives, 50,000 lives in total. Do you have a sense of all the people that qualify for PrEP? How many people actually get it?
It seems to be a lot fewer than should be on it. And, part of that has to do with just asking about it. There are so many things to talk about in the clinic visit, finding time to go in, detailed sexual history, finding out people have these risk factors, it's challenging. The other part is disclosure. People may not want to talk about it or may not feel comfortable talking about it.
Well, I guess that's what my question was kind of angling more towards. Do you think this is something that you'd have greater success with if you identified just sort of a preliminary screen of your patients that you think would even be considered for that and have them fill out a survey or do that online risk tool in the privacy of their own home and then contact you if they self-identify? Do you think there's any value, or have you heard of anybody doing it in that?
Yeah, absolutely. I mean, the recommendation and going through some of these papers they put out about guidelines is, and I do it in my clinic too, is whenever I am meeting a new patient, talking about their sexual history, I ask the question, do you have sex with men, women, or both? And that's just the question. There's no, judgment or morality about it. It's purely a, who are you having sex with? And, a lot of people are taken aback, and it's okay, but they recommend actually that exact phrasing in one of the papers, which is, just ask about it. That's the biggest step. If you don't feel comfortable asking about it, you can either give them the tool. You have to be cautious. You don't want to send them home with something that's going to, cause trouble for them at home potentially if they have people that don't know about their activity. But these are great tools. And like I said, they're online. They can do it on their phone. It's very private. So you can either have a printout that you could give. You can print these out very easily, or you can direct them to the website. That's a good way to see who, might be a good candidate.
Okay. Well, thank you so much for giving us this talk. I thought it was really well organized, and I thought it really hit right on the main points that I think the general internist needs to know. I think you've really pushed everybody's knowledge forward on this topic. Thank you.
Thanks.